just set it over here. If I use something and I finish it, like I finished doing everything I do with the pen light on the head, and I'm just going to toss it to the side so it's clear of my zone, so I got that. That's just something to help you out with it. So, primary assessment, do you guys want me to demo that? Primary assessment is going to be all verbal, so it's just decided which. Your sample history is going to be verbal based on your findings in your primary assessment. If your patient's unconscious or unresponsive or responsive only to verbal or painful stimuli, then you just say, if my patient was able to understand me or respond to me, I do a sample history. You don't need to actually ask the questions, you just need to demonstrate that you know what it means. When you get into the actual detailed assessment, when you guys test this, it will be, depending on how many TAs we show up, hopefully it'll be a TA that you're doing the exam on, otherwise it will be a fellow student. If it is, in the event that it is a fellow student, and this extends to any other skill, any kind of movements, sounds, or indications that could look like you are giving hints, the testing student will get you both failed. So you'd be like dead still when you're if you're the patient. Okay. So pictures. So for the NatReg skill sheet, does anybody have received skills manual on NatReg? I want to make sure that there's no major contradictions. Can you toss me on top of that?
So for the primary assessment, you said it's like pretty much all verbal. So you go through, it's like, oh no, I was taking a pulse, and then you ask, and then the TA will tell you what it is.
Yes. Because when you do your ABC assessment for the primary, you'll get, okay, I'm going to check for presence, rate, rhythm, and quality of breathing. Okay, your presence, he's breathing, rhythm and quality, he's breathing 20 times a minute, shallow, but normal. So you'll get that verbal return. Did everybody get a chance to go through the actual Proctor station last Friday? Nope.
Yeah, but two people did it completely different, so I'm confused. So one person just let us go completely through, just saying the primary assessment over again like we did the first time, but the second person made us well, is the scene safe? They would say, and they would talk back to us, yes, it's safe. And then, so I don't know what because it's like they
you should get
wanted us to AFPU, but ask if they were alert, like that. To person FaceTime with them, we had to ask them. So I was confused. Do you just need to verbalize it all, or do you have to?
You're going to get responses, so you don't want to just verbalize it. You want to hear what's being said back to you. So when you go through it, I'm going to assess my patients welcome consciousness and AFPU, alert, the alert, or there's also verbal or unresponsive. You'll get your patient responsive, verbal only or unresponsive. So the way that it will work, and I'll make sure it's standardized across all the TAs on Friday, is that it's going to be a question and answer format. So when you go through your primary assessment, primary assessment will be all verbal. You don't need to touch your patient. Primary assessment is pretty much all questions anyway, at least in the initial portion. And if it's a part that's determine the level or determine the chief complaint, that's something where you determine if your scenario given is somebody ejected from a car, a 60-foot ejection from a rollover, the chief complaint is traumatic ejection from the car, 60 feet from the car. So if you have somebody who's unresponsive, you can make that up. But the key point here is that you've already tested the primary assessment. You know that you know how to do it. So the primary assessment is not really the biggest part of what we're testing here. It will be entirely verbal for the primary assessment. You are absolutely entitled to be hands-on if that helps you. It's not going to count against it, but verbal is acceptable. I think it's a little bit easier for that. Yes, and you'll get responses. So when you get to anything that has a response, you'll get a response. But on the same side of the coin, you can't just say, I would determine need for C-spine. You would say, you can say that and then say, I would C-spine this patient or I would not. But you have to get in the habit of not just leaving that as a, I would do this if I had to in the field for real. You would either say at that point, because this patient was ejected, I would direct my partner to C-spine or whatever. That's fine. That's one way of saying it. Or you can say, I would determine if a patient has need for C-spine, and because he's been ejected from the car, he has need for C-spine for this particular scenario. So what I don't want you guys to do, and technically speaking, this will not lose you the point if you just say, I would determine if patient has C-spine. But I also want to make sure you guys start getting out of the habit of that like testing mindset, so it's more of a practical application. So you want to be making those decisions and start to think about making those decisions instead of just considering yeah, be more engaged with it, because you don't want to roll up and assume this will happen. You know, the first major trauma you have, okay, primary assessment, got it, and then you have to try and wing it. But what I don't want you guys to do is say, okay, well, I want you guys to get engaged, because you stay back and keep assessing, like, okay, I would do this in training. Training is what's going to come back to you when you go to play for learning. So try and get in the habit of not asking the questions per se, but making statements, unless it's something that you need a response from the proctor. Okay. So the primary differences between the skill sheets, like I said in the main class, is basically just that it's there's more stuff on the Cabrillo sheet than there is on the red sheet. And that red sheet should be considered a summary. And so that red should be considered a summary, with the ones preceding it considered the kind of encyclopedic what you should do. So specifically the one before. If you look basically between these two things, there's some things we say that the average doesn't, but they're pretty much in line. There's only a couple things that are different, and I can't remember off the top of my head what they are, but we'll find out as we go. For the actual hands-on portion, you're doing a good job with for the actual hands-on portion, you're going to be making contact with your patient, so wear DSI or have clean hands, or so just don't come up with breakdown. When you do your assessment, I need you guys to get in and palpate. It's not going to be, I am assessing you have BTLS, they kind of like poking around his head. If you're going to do that, if you're going to do a scalp assessment starting at the top, and you have your gloves on, you can look in the back, palpate across the scalp, check your gloves for blood. That's going to be how you're going to make that assessment. It's not going to be like, I checked the scalp for DTAP BTLS, and I need to know that you guys understand how much of a tactile skill this is. So, make sure to go when you do the palpation. So, when you do your checks for ears, nose, and mouth, use your pen light. I don't know how many of you guys really see in the dark, but you'll be able to see using this, see in the areas that shades back. It's not a whole lot light. So, when you get low, look in the ears. Make sure there's no CSF bleeding. Check the back, battle signs like that. You recognize, you don't need this because you can see, but when you plug me into your right chamber, gently, all you have to do is look. You'll see, in reality, you'll see it'll pretty well out. It'll look different. You go up the nose, check, inside the mouth, open the mouth, check around like that, nothing like that. Then we're looking for broken teeth, noisy airway sounds, unusual odors or lacerations on the tongue. You will smell unusual odors. You get up, open your mouth, and smell. That would be most of the when you do your pearl check, make sure to cover the eye, because it's not going to be any good. You just kind of do this. You want to have the other eye covered. Coming from that side, check, and then the other side, check, and you're done. You will, as you're going through this, the TA's proctors will be silent until you hit something that's relevant. Injury sheet. So if his pupils are sluggish, I'll tell you again. But if they're normal or any other body system is normal, I'll just be quiet. So you just keep going through your checks. Bring a piece of paper in so you can write down the injuries. You don't forget one, because that's a sure way to fail. And even in the field, I pull the tape, medical tape, and put it on my DVD pants so I can write down stuff as I go. Just if it's a short term. Like a goldfish.
Wait, so what I need to write down, like a test, when you write down all of these, or again for YouTube?
Well, you're going to have to assess your treatments on that. So what I don't want you guys to do is go, okay, because some of them have a lot of injuries, so this is just really last week. I don't want you guys to go, okay, I treated all this, because it is a simulation, you may be something that's a lot of leg issue for that to treat. So I recommend, it's not required, but you can come up with a test with a blank piece of paper and pen. Taking notes is a good way to kind of organize your thoughts. If you're able to remember that you want the optimal part of your mind, that's fine. Just for that. Let's see, is there any other nothing that's particularly difficult on the head. The pen light, the same thing we use the pen light. You can pretty much chuck this in your life, right? So we're left with just the stethoscope, so I have a tool that we're going to have to use. Okay, moving on to the neck. When you pop up the neck, I want you guys to go from C1, so it's up way up high. You can't even really feel it because you get that little groove. You go all the way down the neck, all the way down to C7. That's a full palpate. So it's going to look like that. Again, decap BTLS. You can either go body system by body system and say, I would check for decap BTLS of the neck, of the chest, of the stomach, or you can go, once you define it in the beginning, you can say, for the purpose of this scenario, I'll be inspecting for decap BTLS of every body system I come to. You don't have to say it after that, as long as you correctly define what it is. For the JVD vein distension and tracheal deviation medical alert tag, because this is a visual thing, on the NAT registry sheet it just says position trachea and JVD. So if you've dropped the medical alert tag, that's not going to lose you a point. However, it's good to remember, but it's not critical for a trauma track. Same thing with stomach. So some of the medical alert tag, they're important, but at the same time, as I was saying with the visual assessment, in terms of discretionary scoring, if you forget them, it would be obvious if this is real vision, there's real things. So as far as discretionary scoring goes, you probably wouldn't lose the point from that. However, trachea deviation and JVD are specifically referenced on the average point piece. Those ones are for sure. At this point, we do the C-collar check. If you've determined the need for C-spine or C-collar early on in the call during your primary assessment, I or whoever else is testing will tell you at that point the C-spine is being managed by your second rescuers or your ghost rescuers. You will not have to worry about that for the rest of the call. Once you made that call that C-spine is a necessity, it's being done by the people. You made that call, you made that the orders. You've all had your C-spine check box. You all know how to use C-collar and how to put them on the board.
As you run over the neck, you do stuff to say how you know why
That's not going to do that. You don't. So if you made the call for C-spine early on, it's assumed that would belong. If you do, that's great. It's not going to be against you. Just let you down. Nobody's going to give you a 10 minute time limit, so I can almost guarantee you that people will be done by the minutes. You go way faster when you're actually testing. Okay, yeah, so you don't need to do the verbal C-spine or C-collar application. Chest, when you do your barrel hoop, make sure to actually get a good hoop. You want to push in, make sure the ribs are all stable. When you do your sternum press, it almost looks like a karate chop. You just do a sternum press. Women have breasts, this is a fact of biology. Get over it and assess your patients. So you do proper assessment for that. So barrel hoop and sternum press. The still sheets we have say we're also looking for scars, peridoxical motion, any kind of surgical scars, especially chest cracks. For the purpose of this test, it says inspect the chest as the 1 point on the NAT reg. That definitely includes scars and peridoxical motion. However, when you go to say, I'm going to inspect the chest and barrel for stability and palpate, so inspect, we will tell you that there is scars or paradoxical motion or anything that you would see. Anytime you say you inspect the body system, you'll get return of data that's relevant to that. So we won't necessarily need to verbalize that specifically, because if it's not part of the call, we won't tell you it exists. The only other thing on the chest is we're going to auscultate. Is everybody familiar with where the actual auscultation zones are? Okay. Yeah. The ones that are minimum for an anterior assessment is midclavicular, 3 fingers down. So these are going to be at 2 spots on the anterior side, and then axillary is going to be at the nipple line in the axillary area. These are the 2 minimum spots bilaterally that you want to get for a frontal assessment. When you do on the back, you can just do the either the one that's interior scapular or you can do subscapular. It doesn't matter. Because you're drawing a picture. If you think here, right, we've got the upper lobes, lung, middle lobe. You can do lower lobe here, you can do middle again. Because for the trauma assessment, we're just inspecting really for diminished or loss of breath sounds. We're not so worried about wheezing or anything like that. As we're still relevant. You are totally entitled to do, and I always encourage doing a full picture lung assessment, so full front and full back. But bare minimum is these front 4 zones, 2 zones technically. Once we've done that, you may be tempted to throw this off, but remember we have the posterior sounds. Those aren't going to be technically those aren't going to be a failure point, because on that reg seal sheet,
Consider also.
yeah, it's a consider. So you should. It will lose you the point if you have any kind of abnormality. If your patient's breathing normally, if your trauma patient's breathing normally, and you've got clear lung sounds on the front, and you consider that you don't need to worry about that. However, if you get diminished lung sounds or absent lung sounds, you definitely want to focus your so I'm going to hang on to it because we'll say my trauma patient's got lung sounds issues. If you go to the abdomen, this is actually really probably one of the least amount of point areas. There's a lot more on our skill sheet than there is on the NAT reg one. The NAT reg all it wants is inspection and palpation of the abdomen. What I do want everybody knows the 4 quadrants. I would like you guys to state that you're inspecting for distension, rigidity, guard, and those masses, but that will not be a point against you. This NAT reg is a large departure from our old testing because it's a heck of a lot easier. It's both good and not good for you. So you should absolutely bear in mind that you should spend an extra time to know and to stay at what you're looking for, because that's the only way to benefit you further down the road. But for actual palpation, for abdomen, we're just going to do our 4 quadrants. If there's any mention of pain in any 4 quadrants, right, we do that one last. For pelvis, push in, push down, check for stability, and then we're going to check for, it says, for the NAT reg, it says verbalize assessment of genitalia decline is needed. This is where you just say, I'm looking for pregnancy and incontinence or bleeding. That's all that point is. Pretty easy. That's our total assessment for the lower half of the trunk. So it's kind of simple. When we do our extremity assessments, the way I want you guys to see you guys palpate is not, I've been seeing a lot of people doing this, which is awesome for soft tissue palpation, but it's still going to do nothing for the bones. What you need to do is do a counter push. You want one hand on one end of the bone, the other on the other, and you're going to push against that. If there's any breaks or fractures, that's where you're going to see it evident. You're going to feel the cavitation or hear it, and your patient probably going to yell at you. This is not going to find, it's going to find soft tissue injury, but it's not going to find bone or structural injury. So when you do a full palpation, will be up and down, inside to side. It doesn't matter, you don't have to do both, and you should not do both because you don't want to put your hand up on the patient's crotch unless you need to. So you do up and down, side to side, and then you do it on all parts of the limbs. So you do the same. There's no gun.
It was actually that lady.
Awesome. PSI. Okay, so there's a lower leg palpation. That includes the ankles, so it's not going to be a failure point, but when you're doing a proper palpation, you should feel all the way down to the feet and the ankle joints and every part of the leg that you're palpating. Crepitation is not something you're going to find unless you move down. For our feet, we do our PMS checks. A lot of the patients in these scenarios are going to be either unresponsive or responsive only painful. So you're still going to need to verbalize. You do a PMS check, perfusion, motor function, sensation. However, you're only going to get perfusion, right? A pulse or cap refill. So cap refill is a valid check for perfusion. There's been kind of, I've heard some different talks on that, but it is valid. If it's less than 2 seconds, it's positive, or it's good perfusion. Anything over than 2 is more perfusion. I would recommend doing cap refill because finding the pedal pulses are a pain in the ass, and they move around. Colloquially, they'll actually. So if you do find it, mark it. If you don't find it, go for a cap refill, or just do ID only trauma assessments, which is just go straight for a cap refill. Saves time. Your upper assessments, same thing. You're going to do up, down on the major long bones. Check the bones of the wrist, just like we do the bones of the ankle. You do your PMS check. Lower your fingers for me. Gotta grab one of my hands. You want to do this bilaterally if you can, if your patient's alert. Otherwise, you can get your pulse. If you can't find that for whatever reason, you can cap refill. Less than 2 seconds period. Over 2 seconds bad. Check the medical order tags here. Remember, it's not going to be pointed against you. Again, that's something that would be visually obvious. Once we've cleared our extremities, we're going to do the roll. There should be enough people in every test between. You know if we're doing, is Shane having us doing it with them having assistants again?
It's probably going to be student assistants.
Yeah, you're not going to use. Okay, so you can direct, when you do a proper roll, do it correctly, have a second person help you do that. Hopping up the leg is not a mandatory, it's taught, it's good form because it helps, realistically all it really does is give you a good point of leverage, but you can still work around it. So when you roll, do your palpations. So start at C7 where we left off in the neck and go all the way down to the lumbar and sacral vertebrae. You can either verbalize or you can do a sweep. Realistically, the sweep. Remember that for a proper trauma assessment, your patients are going to be naked, so a sweep isn't necessary in most cases because you can visually see. You can remember here now that you got your stethoscope around that you want to do your auscultation for the posterior lung sounds. So we do that. We can toss it to the side. We've got nothing else in our hand that we brought in, so we know that we're done with any of our physical things that we brought in with us. We know that we're focused on all of those. When we're rolling back, basically we're just going to roll back like that, which should have your second SU help you out. Then we're going to go on to managing any secondary injuries and wounds appropriately in our vital signs. Yeah, dying Siri.
I have a question.
Where did you print this from? Yes.
So when you roll them over,
It's just a different sheet than what we have.
It's NRAT.org.
Yeah.
when you roll them on the back, if you didn't also say his lung sounds on his back before, you don't have to do it again.
Because it's discretionary, right? Because we say, consider auscultating posterior lung sounds. When I say, it's not a hard rule, but if you have a patient that has clear lung sounds in the front and they've got no chest trauma, then it's discretionary. You probably don't need to worry about the posterior lung sounds.
But the posterior lung sounds,
If you've got anything bad in the front that you hear, you do want to get the back for the full picture.
Quick question. During the primary and secondary assessment, we're verbalizing interventions for visualized tests as well?
Yes. Yeah, you think verbalizing those. You're not going to get those. Spoiler alert. So don't worry too much about it. But yes, primary assessment, totally verbal. You can absolutely do. You're not going to be dropping OPAs on your patient volunteers. We're testing all airway stuff at paddle station that we're using right now, so I already know when you're attending to me that either you will or you have demonstrated complete competency with OPA insertion and the ambiguous oxygenation. If there were an application, we would be doing that station, so
But I mean, like, in the situation like patients apnea, I mean, say I didn't sort of my assistant background.
yes, yeah, it's verbal. That's why we say you have your two competent and trained rescuers. We don't want to get you caught up because this is a time limit. We don't want to get you bogged down in your time intensive skills because the reality is we're not going to be going on calls on our own. We're going to have team members. That skill sheet is a little bit different than what we're actually using. Vital signs come at the end. Technically speaking, you can get a blood pressure at any point during it if you suspect that may be relevant to your call, but it's not going to point against you if you wait to the designated spot to get it. When you do your blood pressure, and I cannot stress this enough, if you are not comfortable with it, come to me or Kyle or anybody else who's before the test because we will be listening. If you're not within 10%, you're not going to get the point, which, while not a critical failure, will tend against you. Do your blood pressure, then you'll be able to combine your blood pressure that you just got, your pulse that you got, and your respiratory rate that you got during the primary assessment to get your full set of vitals. Being Pearl, but Pearl and skin signs are kind of around deal. What's that? You'll get your pulse and respiratory in the primary assessment verbally. So don't worry about that. Now that you've got your vital signs, you're going to go on to reassess injuries. As you go, any life threats you treat on the way, anything that's secondary or important you treat. When you get your first set of vital signs, that even though the blood pressure is happening right then, you're going to state and how and when you reassess your patient. Critical patients are 5-minute reassess. Stable patients are 100 minutes. So 5 to 15. When you reassess, you're going to be checking at minimum the patient's mentation or vital signs for that. So their ALS status, their ABPU, their GCS if you want to get real fancy, and vital signs. That's minimum. On top of that, you're going to make your assessment decisions based on what they presented. If they have a broken leg and you splinted that, you're going to reassess your splint. If they have a collapsed lung and you noted that, you're going to reassess that lung. You're going to reassess any injury that requires reassessment. You need to reassess abrasions and that kind of stuff. Anything that could change during transport, that's what you're going to have to do reassessment. Anything I didn't demonstrate? sufficiently enough that you guys want to go over?
What the proctor statements the same in the book, or you changed them?
They're not the same. You'll get the initial proctor statement is going to be the same, but the scenario is going to be different. The one you guys got last week is not in use in this in the test this week.
BP cup. Are we going to be applying one?
Say again?
Are we going to be applying a BP cup on him?
Yes, you're going to be taking his blood pressure.
Okay.
Your patient's blood pressure, because we have a dual-headed stethoscope. So it's got one diaphragm and it's got two ear ends. So we'll be listening along with you, and then what we hear we're gonna write down, and then your value that you tell us is going to have to be within 10%. That's why it's kind of separate from the after you made all your decisions, because it's not going to be what the simulated patient's blood pressure is. It's going to be the actual person's blood pressure. 10% seems like a little bit, but it's quite a lot. It's 12 points on either side of 120 if we're considering average. So it's a lot of leeway. So I wouldn't worry too much about it as long as you're clearly able to get blood pressure and you haven't been having major issues with that. Okay.
So for the recess, you're just saying, oh, I would, like, he's critical, I would assess it 3 to 5 minutes, assess this.
Yeah, I would assess his rotation, his vital signs, plus injuries.
Sorry, what are you reassessing? His vital signs?
Mentation, vital signs, and any injuries that require reassessment. Like I said,
Mentation would be his month.
Yeah, or after.
Okay.
Yeah. Okay. All right. Practice as you feel necessary, and we'll pop around and make sure you guys are